this day. Thank you for bringing folks together, your church, the body, with unique gifts and talents, experiences, knowledge, to benefit one another. Thank you that we're just a small, little, tiny cell in your global church, and I'm just honored to be a part of this body with my brothers and sisters. I pray that this time is beneficial to the body. I pray that this time is fruitful and encouraging for folks here. And most of all, I pray that you're honored and glorified through what we say. And we just praise you, Lord, for what you've done already. In Jesus' name, amen. We're going to do introductions in just a minute, but I want to get a quick pulse on the room. And we've got a pretty small group. So I just want to know how many of you are like pre-FQHC, pre-lookalike, you're like a free charitable clinic. If you'll just raise your hand, like if you're in that state. Okay, so a good number of folks, that's helpful. And then how many of you are either in an FQHC currently or you're very kind of well-versed in the FQHC world? Okay, a few folks. And then how many of you just kind of wandered in here because you saw Sharmien smile and wanted to be part of this group? Yes. Thank you. That's helpful. So we're going to share a little bit of our story. We're going to share some lessons we learned along the way. I think a great quote that we heard this morning in one of our talks was, knowledge is learning from experience. Is that right? Am I saying it right? And wisdom is learning from the experience of others. So was that you, Larry, that said that? Okay. Someone said that this morning. I thought that was really good. Was it Lance? Okay. Yeah. So I hope you're all a little wiser when you leave here as we share this with you. And I am putting this is my cell phone number on the bottom right corner. Please don't post it on social media. But my wife is an extreme introvert, and so I empathize with introverts. If you have a question that you think of during the talk, you can text me, and I'll anonymously ask that question. You can also, Sharmien reminded me, post a question in the app so others can see it, but that's not anonymous, so just a heads up if you want to do that. Okay. I am Tyler Whitaker. I'm currently the CEO at Crossover Health Services. I'm an Okie. I'm a graduate of In His Image Family Medicine Residency Program, and my wife and I and our 3 kids have lived in North Tulsa, which is the underserved part of our city, since 2012.
Why do they give me microphones? I have an audience too? My God. Hi, my name is Sharmien Watkins. I am not an Okie. I just live in Oklahoma, but I was born and raised in Little Rock, Arkansas. I am a wife of Rodney, a mom of Ramari, Raylan, and Rodney III, who we call Trey Trey. I am the grandma of Kalani and Braylon. And I love the Lord. I love my team. And I have a good time. And I also serve as CFO, just in my spare time.
Hi, I'm Holly Bennett. I'm a nurse practitioner. Been at Crossover for about 2.5 years now. Started there as a nurse practitioner and then kind of said, hey, let's fix some quality stuff. And then I became QA/QI director and then eventually transitioning to COO with the help of these guys. But love my team. Love Crossover. It's the only faith-based clinic I've worked at so far. Before that, I worked at for-profit, large corporations, but always wanted to be able to treat patients that had Medicaid or weren't uninsured, and really felt like this was a good fit for me and called to do it.
And I'm Natalie Schaller. I'm a family medicine physician, also trained at In His Image, ironically with Tyler and a few of the gentlemen in the audience. I'm originally from Minnesota. Is anybody here from Minnesota? I didn't think so. But I'm in Oklahoma now, married, and I have 2 kiddos. And we actually spent the first 10 years out of my residency at an underserved, under-resourced FQHC in Storm Lake, Iowa, where I was a medical director. And then I moved back a year and a half ago to help with this transition. So I'm serving as the CMO right now at Crossover Health Services. So glad you guys are all here. We wanted to share a verse that's been really so encouraging and inspiring for our hearts and helping us to persevere in this time. So it's from Galatians 6:9. And let us not grow weary of doing good, for in due season we will reap if we do not give up. We have a typo there. I just saw that as I read that. Okay.
I just really quick want to go back to this slide because we are representing an amazing team of about 22, 23 individuals who day in and day out sacrifice to serve one another and serve our patients. You can tell it's a pretty diverse group except for the gender diversification, and so I'm actively recruiting more male members to come join our team. So. But we have a blast together. It's a roller coaster. There are definitely ups and downs. But so this has been a journey. I just quickly want to share how the clinic started, kind of the birth of the clinic, and then more about why the decision was made to go down the lookalike route. So the clinic actually started out of a church called Crossover Bible Church. The church actually began in 2006 and was located in North Tulsa, which is the underserved part of our city. There's a couple of our team members. Welcome. And our pastor, Philip, really wanted to be a church of impact in the community. And one of the things I hear him say a lot is, if the church were to close its doors, would the community notice? Would they lose something if we were gone? And so that's really motivated the ministries throughout the years. And around that time, there was a lot of attention paid to the health disparities in that part of the city. During that time, there was a 15-year life discrepancy between North Tulsa and South Tulsa in terms of your lifespan, and access to care was directly related to that, as well as the other social determinants of health that we're aware of. So in 2014, the church, along with help from CCHF and actually Christ Community folks, decided to launch a clinic. Dr. Kent Farish retired from his private practice, along with Nurse Louise and Office Manager Angela Barnett and Nurse Tasha, launched out on this pioneer course to start a clinic in North Tulsa. It was really started as sort of a private practice model with a cash pay system for uninsured patients. So over the years, God blessed it, continued to grow. These are my residency classmates, started residency in Tulsa in 2012. My wife and I moved into North Tulsa, got plugged in at Crossover around the same time, 2014, and then God just kind of put me on a path to step in more and more at Crossover over the years. So fast forward really 3 years ago, I'd say 3 years ago, was when these conversations started about longevity and sustainability, and how are we going to keep doing this, for decades to come, because that was really the vision, is to see community health transformation and to see these health disparities addressed in our community. We realized that was not going to happen in the short term, and it needed to happen on a larger scale. So kind of the crossroads was, we can keep doing what we're doing right now. There's nothing wrong with that, and I want to acknowledge that even now. Like, if you're part of a free and charitable clinic, a small volunteer-based driven clinic, there's nothing wrong with that, and that's amazing. And we considered that, and then also considered alternatives such as the FQHC route to tap into some more resources, some more access to comprehensive care, and to really try to grow this thing so it could have an impact on the community scale. And that was eventually what the board decided to do. So that decision was really made in 2021. And then we started down that path. We, around the same time, opened our second location So we operate 2 clinic sites in North Tulsa. We have 6 providers total currently. And yeah, we, over the past 3 years, I had run these numbers recently, we're around 3,400, 3,500 unduplicated patients over the past 3 years, around 15,000 patient visits. So God has done good work. Okay, quick outline. We're really going to try to marry our story with some pearls and some lessons that we've learned along the way. If we tried to unload on you everything we've learned over the past 2 years, you would feel like I felt as I was listening to Art this morning share about Medicaid cuts. But we want to go over really the key topics and considerations in the FQHC and HRSA world. Those 3 areas they really focus on are the governance and structure of your clinic, the clinical operations and financial systems. Along with that comes strategic planning and quality. So we're going to hit on all of those. Okay, this is, real quick, I just want to make sure I don't have any questions yet. My section over governance and strategic planning. One of the, I think, key questions to ask early on if you're considering this is, do we actually have a need in our community for this, for an FQHC or a lookalike? And so conducting a community needs assessment is crucial for that. And there are many ways to go about doing that. But I'll tell you briefly what we did at our clinic. We started with community input, and that was really huge. So Angela and Dr. Farish and Nurse Louise went out and listened to neighbors, held listening sessions and really asked the community, what do you all want, or what do you need in terms of healthcare, and started there. I think another cool part of our model is it's modeled after the Dr. Perkins CCDA model, the 3 R's, relocation, redistribution, and reconciliation. And so a lot of our team members live in North Tulsa and are asked to consider being part of the community so that we're not coming from the outside in, but we're integrated, that we're neighbors with our patients, and it's our community. It's not us and them, but it's just us. So that is really key, I think, to start with listening. And then data mining, researching, and collection. I want to really plug SparkMap. Have any of you used SparkMap before? It's an amazing tool. You can just Google SparkMap. It'll take you to the webpage. There's a membership subscription that will give you access to zip code level community health statistics. And you just plug in, like we plugged in our 10 target zip codes, and it spits out 400 pages of everything you could ever want to know about community health in your area. And that's just one example of one of the charts it generates, in terms of income in the population in our community. So you can see on the map that, our zip code target areas are in the dark blue. Over 40% of our patient population is below the 185% federally poverty level. So I plugged that because that saved hours and hours of research. And you can use these graphs, and it even spits out narratives that you can plug and play into your narrative for the application. So it's super handy, and even with funders and donors, to have these statistics ready at hand. HRSA has other tools that you can use. The GeoCare Navigator, the medically underserved area find tool, and the unmet needs score tool are also helpful. And then we partner with our local health department to pull statistics that we weren't able to generate in other ways. And then getting with your board, which we'll talk a little bit about in just a second, but starting to develop a strategic plan based on what you heard from the community and then the needs you've identified in your needs assessment and really aligning those with HRSA's priority of comprehensive, high-quality care are, critical. And that really helps you answer the question, is this needed in our community, and can we actually do something about it? I think our key up front. Okay. I think we're doing okay. So I'm not going to bog you down too much in these details, but HRSA is very specific about how they want you to form your board if you're considering pursuing lookalike status or FQHC status. And the main thing they want is a patient or consumer-driven board. So 51% of your board have to be active patients on your panel. And, you can get creative with that. Sometimes, you just ask a board member maybe to have a sick visit and get on your role. But we do have, most of our patient board members are genuine patients that we are their primary care office. And we depend on them for feedback. It's like we were talking about this morning, like they will come and tell us if something is off or if there was a bad experience. They have feedback with us, and that's really the point. And HRSA really wants to see the demographic of the community and the patient population represented on the board as well. So this is a good plug real quick. The handouts you have in front of you, you don't have to get into them right now because we don't want to overwhelm you with information, but there are a list of resources that we found helpful, and one of those is this board matrix that I think I have up that we really used to help guide the formation of our board structure. We were given this by another FQHC, and it really drills into the details of what HRSA wants to see on your board. So I have created a folder that has this file in it. It's a blank one, and other resources that if you're interested at the end of this and you would like that folder sent to you with some of these resources, we can send that out, okay? Because we just found it so helpful to have so many of these things as we were going through this. And the other important thing, just as you're forward thinking about jumping into this, is your C-suite. So HRSA requires, at a minimum, a CEO, a CMO, and a CFO position that are full-time for your organization to govern it. So we had to recruit and hire these amazing folks who would jump into this, a leap of faith, to join in this effort and really play an integral part through the application process and eventually the site visit. And then briefly on maintaining mission while meeting federal requirements, we are registered as a religious non-for-profit, so we are allowed to be Christian. We can be outspoken in our bylaws about our Christian faith. We are outspoken as Christian doctors. We do not proselytize, but we do provide spiritual care for our staff and our patients. And we serve anyone and everyone, just as Jesus would. There is a great resource called the Alliance for Defending Freedom that, if you haven't heard of, has been really helpful for us in forming our bylaws and helping us protect our mission in the bylaws while also remaining compliant with HRSA standards and requirements. So the other handout you have on your table, yes, sir.
I'm sorry, I don't know if it's okay to.
Yeah,
Yes.
let's go.
I just want to share that HRSA is brilliant.
That's good. I'll just repeat that for the recording. So the point is, on your board structure and the demographic requirements, that board members can be representative even of family members who are patients of the clinic, of a different ethnicity, culture, race. It doesn't have to be a direct lineage or connection. Okay, a couple more things before I wrap up this section. The other handout you have in front of you is a timeline that we tried to outline just as you're thinking ahead. This process takes a while. So it took us, about 2 years. Would you say? Well, I was just thinking even back before, like even the initial conversation. So a year once you all, dove in. Yeah.
Definitely.
So that timeline just kind of helps you walk out things to think through along the way, and it's too much to go into here and now. So you have that at the ready. But the big thing is board recruitment can take a while, like we were talking about this morning, being very selective about mission fit with your board members, because they have the ultimate say on governance, and they're the boss over the CEO. So mission fit is crucial in that. And then also I want to touch briefly on the documentation requirements for board meetings. That HRSA really loves to see conversation and discussion in the board about the various topics that you're covering. So Dr. Schaller, God bless her, has been so amazing at taking notes during our board meetings. And during our site visit, they pointed out specific conversations and discussions that were had in the board meeting minutes that they really appreciated seeing. So just kind of keep that in mind. And then lastly, just thinking about strategic partnerships you can begin forming in the community that Dr. Schaller is going to get into in just a minute, all of the clinical requirements that HRSA expects you to comply with. So we're partnered with the health department. We're partnered with local hospitals for imaging. We're partnered with local residencies for OB. So just different strategic partnerships that took time to form.
How many of you are familiar with Form 5A? It's like, it's like this huge burden in the true FQHC world. So I don't put it out there as something that I want to bog anyone down with, but just make it familiar for those of you who might be pursuing lookalike status or fully funded FQHC status in the future. So this is sort of this big beast that we found, and just want to briefly introduce you to it because I think it was one of the most cumbersome pieces for us on the clinical side. So this is the form that's going to really describe your scope of practice, and I just want to share a few pearls. It's the documentation of how your required and your additional services are being provided through your health center. So there's 3 big columns, and I'm just going to quickly touch on this. So there's column 1, those are the services that you directly provide within your health center. Column 2 are the services that you contract out with. Column 3 are the referrals. So I do have our Form 5A up here, and you can see it's not, I didn't put my X's in a perfect row. I really put the real document in so you guys can see it. But I did just want to sort of make the point that one thing we found really helpful and why it's so important to bring as many of your services that you can, all of the required services that you can in-house, is it also makes this form a lot easier. So you can just check column 1 for everything. If you do OB, if you do all the things in your office. Yes, sir.
Are there minimum services that person requires?
Yes. Yep. And they list it. You'll get a big binder and a form with the application. So yeah, there's the required, and then there's additional, and they describe all of that, so I won't run through every single one. But some of the things for us that fall in column 1, it's direct primary care. We do CLIA waived labs, so we have that in-house. Outreach, brief education, transportation, those sorts of things. Those all fall in our column 1. Column 2, and like I said, if this is a little overwhelming, don't worry. It's just more exposure in case you do go down this road. You'll be like, oh, I heard about Form 5A, and now some of this makes a little bit more sense as you look at it. But these would be sort of your contracted services. So lab, like DLO, radiology, those entities are the ones that would be our contracted services. And then column 3 would be the formal referrals, those written agreements. So we do not, none of our providers do deliveries, so we contract out for that service. A huge pearl we would love to share with you is if you think you're going to go down this road, is to start looking at your contracts early, because that was a huge, just a huge way, honestly, that God provided for us, because we had to have some contracts pushed through pretty quickly at the end. And, some of this, we were navigating contracts for OB care with some bigger entities that, they don't really care about our timeline, but by God's grace, we were able to get them done in time because HRSA wants to review all of that for your site visit. So if you're at all thinking about this, you might just kind of look at the compliance manual and HRSA recommendations, there's just some specific verbiage. For example, they want your OB contract to state something really specific about them making sure their providers do risk management training. You know, there's just little nuances. So this is, like I said, just exposure, making you think about it. This is sort of switching directions, but something big on my heart that I wanted to share with you in my time of what I've learned and sort of our heart as a team for the clinic in general is our heart to make this the best clinic climate possible, make it the best place to work. And this comes from 1 John 4:19. We love because he first loved us. So I think we would all agree there's more than enough work, and we can burn ourselves out, and we can burn our staff out, and we can continue to ask more. But what does it look like for us to serve our staff? What does it look like to offload the burden as much as possible? So just some things that we really started to pursue. We found an after-hours phone call triage system so that our staff wouldn't be taking the phones home anymore. We're trying as best we can to give the best salaries that we can for each position, especially making it marketplace value where we can. Of course, not on all levels, as you know. But you know, we maybe can't offer all the bells and whistles that some of the entities down the road can. But our hope and our prayers that this really will be the best climate where staff feel loved, where they know they're treasured, where they know they're not, their value doesn't exist in what they do or what they produce, but we value them because God loves them and we love them too. So, Christmas party. We have really exciting Christmas parties if you ever want to come to Tulsa. Okay, it's Miss Sharmien's turn. And I do just want to say this. Sharmien is probably one of the most fun financial individuals I've ever met. So you're going to love this. It's gonna be
What a lead-in. So, as I shared with Natalie and Holly earlier, my opening line is, forget everything we said a few minutes ago. Run. Run now. Save yourself. At least that's how we felt a few times as we went through this process. And for some that were in the executive meeting earlier, we had one of our options to choose was pray, hope, and wait. Okay, and we took that to heart. This requires a whole lot of prayer. This also requires a whole lot of faith. This then also requires a whole lot of resources. And so I'm reminded of a Bible verse, forsake not the fellowship of the saints. And I will tell you, it is truly because of the fellowship that we engage with other FQHCs, lookalikes, consultants, that God's favor really showed up on our behalf and for his glory, truly. So dynamic people like Mr. Larry Rector, I could not have done anything in the realm of what I was working through without his guidance, his leadership, his stewardship, because he literally took me hand by hand through it all. And there are tons of resources out there, but I think the best resource is a human being that can walk with you, talk with you, encourage you, and show you that. And so God opened up our hearts and opened up so many people who literally poured into us. They sent us policies, things just works and deeds and words of encouragement. So build yourself a good executive team, but build yourself a good village that will walk you through this process, because it just takes that. It really, really does. So naturally, there's so many financial management procedures and various things that you will become intimately familiar with, and start with a good Google search. And we all have Google, yes. Start with a good Google search. When you pull down the application requirements that's about yay thick, and we made everybody a bright, shiny red binder, And we divided it up in sections. You do this, I'll do this, you do this, and we'll come together and we'll work on those together. Many of the requirements are documented, right? And they speak in their own language. Would that be fair to say? HRSA speak is a real thing. You have absolutely no idea what these people are talking about. So you need an interpreter, and that's when guys like Larry and others who've gone through the process, and hopefully for us, because it would be a blessing to us to get to pour into you the way that so many poured into us. So kind of like Natalie, and as well as Tyler, we could bore you with all the details, but the big things are there are specific financial policies that you must have, okay? All of which are outlined in the application packet and the HRSA requirements, too many to name. You want to, the biggest thing that there will, which was probably one of the most interesting and engaging processes to do, was to create a sliding fee discount program. That was interesting because, of course, you know, we're the smart ones. We know how to do this. We can talk this thing through. And so we put together this elaborate chart of what we thought it was supposed to be, only to find out, no, you must get community engagement, and you have to talk to people. And not only in that conversation, you have to document why is $25 appropriate as opposed to 30, or why should it be, you know, what really meets the needs of our community. You'll also find that there are FQHCs who actually have this program, but you don't want, those participants don't have to show financial need. You get to kind of structure it the way that you want to within the HRSA guidelines, but you gotta show what you know. In other words, like kids do with tests, you gotta show what you know. That's the whole point of the site visit. You gotta show why we came up with this number. Here's the documentation to justify that. Here are the conversations that we had to do it. And does this really meet the need of our community? So the big thing I would also say about that is it does take time. So the timeline is important because you have a whole lot of input that you have to take into consideration as you're putting that together. But if there was one policy I would say that was the most interesting and intricate to do, it is that sliding fee discount program. So spend a lot of time on that and enjoy the journey in that. Funding opportunities and fiscal transitions. Interesting, okay? There's a whole lot that comes into this, particularly because we started out as a private practice. So we were going all the way down one lane. All of our payers were in the mix. We finally knew how to work our EMR system. All systems were go. And then we became a lookalike, and all that stuff changes. Everything that you thought you knew, it ain't the same. So the cool thing about it, and one of the reasons why we wanted to do it, particularly for sustainability, is some of the enhanced reimbursement rates that you are allowed once you become a lookalike, or in fact, full FQHC status. Certainly, everybody wants to be a full FQHC with the NAP grant and nice little chunk of money in the bank that still helps you to starve, but no, will definitely be a boost to the community. So there are definitely enhanced Medicare and Medicaid rates. You will have the opportunity to receive other grant funding. So not just federal, but state funding also. So you want to make sure that you avail yourself to those things. And again, it's all about being able to continue to do what we love, serve who God has called us to serve, and be a community partner for our community. And we can get to the numbers. Yes, please. Minimum requirement, like we have to make this amount of money in order? No. But you have to sustain, there are budgeting requirements in that we have to produce a budget that describes how we would use the grant funding, what's grant funded, what would not be grant funding, what will come just from normal operations. So there is a budgeting section within the application.
Let me just repeat that for the recording. So the question was, can you still receive funding from outside sources once you become a lookalike or FQHC? And the answer is yes.
Yes.
Yeah.
And you will need to. You will still need to. Most of our outside funding, well, of course we have patient visits, so just regular retail, if you will. But we also, and we receive insurance reimbursements, so we're still contracted with all of our insurance payers. So you kind of work in both sides of the house, right? So you have just almost like regular operations of a for-profit clinic, and you also have this opportunity to serve via programs through grant funding as well.
Can I jump in real quick? So I think that brings up a really good point, that this transition is really costly in terms of time and finances. So you really need like a base of foundations, not fees, but you've got to pay a salary for a CFO, unless you've got a saint who's going to volunteer as a CFO for free, a CMO, a CEO. You got to pay your providers, so unless you're just entirely volunteer based and you're going to go for this, you've got to bridge that gap, from going to an FQHC look-alike staff and the requirements they have, with funding. And that's how we did it. We had private, funding to help us kind of bridge that transition. So that's good. Yeah.
You will need outside sources to sustain you. And after, in addition to, right. So several FQHCs, operate with multiple grant sources and multiple other streams of income, like the 340B pharmacy, or just, offering other health services, i.e. dental services or behavioral health services. All of those things can go into the complete package and mix of sustaining your clinic.
The question was, do we have a lawyer on our team during this process? The Alliance for Defending Freedom was kind of our lawyer and go-to there. So that's a national organization. Essentially, it's a nonprofit for Christian organizations to help them navigate the litigation and legalities around documentation, bylaw formation, protection of ADF, Alliance for Defending Freedom.
But an excellent board member suggestion, a local attorney or someone in your community who could serve in that capacity. As a board member, not quite pro bono, but yeah. They have a vested interest as a board member. Yes.
Question was, did we have to get letters of support from existing FQHCs in town? That's actually one of my pearls at the end, is start reaching out to existing FQHCs early on to form those partnerships and friendships.
So when we kind of put together our quality assurance and quality improvement program, it was pretty overwhelming. It was daunting, I would say, when you get that thick compliance manual. So just thinking about it, I wanted to make sure we held true to our values and true to who we're truly called to serve, which is Christ. So picked two values that cross over, holds dear, which is servitude and excellent. We want to serve our community, and we want to serve them with excellence. And two verses that helped me during that time was Colossians 3:23. Whatever you do, work at it with all your heart as working for the Lord. Oh, can you not hear me? Okay. Colossians 3:23. Whatever you do, work at it with all your heart as working for the Lord. And Proverbs 29:18. Where there is no vision, the people perish. Because we all know this saying, if you don't plan, you're going to plan to fail. So you have to have a plan. And this is where I wanted to start. This is our nurse manager, by the way, Carolyn. She is awesome. So start with a policy and start with a plan. So I started with, in the compliance manual, I just looked at the quality chapter and thought, how can we make our QA/QI policy? And so we drafted that based on the compliance manual, and then I made a plan. And you can, like as Ms. Sharmien was saying, you can Google work plans for quality improvement and quality assurance. There's several out there. This is the one that we use because there's so much to keep track of in the world of quality and compliance, especially when HRSA is involved. So you don't want to forget anything. So I use this that has all our measures, how often we do those measures, and then when in the month we do them and who does them. So I look at that every month, and that's been incredibly helpful. And if you want any of these tools, you can text Tyler or reach out to us, and we'll get them for you. And then next, okay, so there's all these policies you have to draft. And some we had in place beforehand, but we didn't. It was a lot of policies. So we made a spreadsheet that basically went over all the policies we needed to draft. And then we highlighted the ones that we needed for HRSA. And this isn't even the whole list. Like, it's way long. This is a snapshot. But we did that, and then I put a column in for has it been drafted, has it been edited, because you want two eyes on it, and then has it been approved by the CEO and then to the board. Yes. So it's definitely a process, and then we color-coded, like, who's it assigned to. Just divvied up all the policies. So I highly encourage that. Then data collection. There are these wonderful things called uniform data systems, which those of you in the FQHC world, I'm getting some smiles, because it is, I love data, and this is a little painful to me. So I would highly encourage Zara Healthcare Software. We actually don't have that right now, but we're going through our Primary Care Association to try to get it, which I greatly look forward to. But just remember, everything's there. The guidelines are there from HRSA. What data you need to collect is there. I put the link on there so you can visit that, and you have to go by their requirements. And sitting at my house, spending all the time in Excel and our EHR, thinking, how am I going to do this? And I just kept reminding myself, if the data exists, you can measure it, and you can get through this. But then get a Zara. That would be my pearl. And then software. So a touch of humor. I know the EHR upgrades are a lot. I know any software implementation is a lot. So it says, so the test results are in, but it looks like we're going to have to need an upgrade to the EHR 2025 to see them. Is that not the world we swim in?
Right.
And I love tech, but it can be a pain. So with all the compliance training that you have to meet for HRSA, and just to be a good organization, to really take care of your people, not only your employees, but the patients, you need to track it and you need to provide it. So we use MedTrainer software, but there's a lot of compliance software out there. And I like MedTrainer too, because every contract we have that we have to keep up with for who needs, it needs to be renewed at a certain time. It gives us a date, an alert. Okay, some quick pearls. Systemize. You need to have a system. So work smarter, not harder. We're human. We're gonna fail at times, but you need those systems in place to keep you safe. So I would do that. And then watch the process. Go talk to the front desk people. See how check-in works. See where there might be room for improvement. And then AI is definitely your friend. We have to embrace the tech. I know that can be controversial, but it definitely helps. It helps with policy writing. It helps with just brainstorming. So definitely I encourage that. And then most importantly, just don't forget to listen to your patients. Don't forget to listen to the community. I mean, what is your why? Serve Christ and let that love pour through you to the community. So just please don't ever forget that. Oh, QA meetings. We schedule these monthly right now. I would love for it to be quarterly, but right now we just need to do it monthly. And you want members from all parts of your organization there. And that is something that HRSA encourages. So you want someone from the front desk. You want someone, the case manager at times. You want somebody from the nursing staff. You want all parts of the organization represented, because all parts need to work well, just like the body of Christ. And then I would highly encourage you, in our QA agenda, we always have a who, what, how, and when, probably to the point that it's almost annoying, but I just don't want anything to get missed. So encourage that too. Do you want me to say my part? Yeah, go ahead. It's kind of repetitive, but as they were saying, just ask for help. Find a buddy. Somebody has done this before, so ask them. Yeah, we were hooked up with another FQHC, and in Ardmore, Oklahoma, and they have been tremendously helpful to us, and so thankful for them. And we would love to be that for anyone else too. So use the compliance manual. Must follow the compliance manual.
Must follow it.
And be systematic. Yeah, don't make your life more complicated than it needs to be. Yep. And then if there's a policy, you must follow it, especially at the site visits. Like, I mean, that's just across the board with any organization.
Just a couple of quick things that I felt on my heart. One is start early, so look at your contracts early. Think about what you need and who you need to partner with. Number two, if there are training opportunities that you can attend, I think those are really helpful. I went to a medical director training a few years ago in Kansas City, and I learned so much, and I wish I would have done that the first year that I was a medical director. My third one, really quickly, is that if it's difficult, it doesn't mean it isn't God's will. On a really huge personal note, I think for all of us, this has been difficult, and I think there have been many moments like, are we supposed to be doing this? Is this really God's will? Are we on the right track? But we really do know and believe that this is what we're supposed to be doing at this point in time in our lives. So we've seen his goodness in it.
I think it's funny, accrual accounting. Yeah, we put accrual there because originally all of our financials were in modified cash, but then it in fact had to be an accrual for our site visit. So imagine spending several days just completely revamping your entire financial system. But been there, done it, even got the T-shirt. So ask me how to do it, I surely can tell you. But definitely find a mentor, a buddy, someone who can speak life into you, who can encourage you, and then you got to find a friend. You need a friend to walk this walk with you, but have fun, because in all of the crazy, it really was fun. We can look back now, and we probably should all be committed or admitted at some point during the process. Go ahead. Yes, it's true. You were there. Yes, sir.
You've mentioned a couple times you broke out program segments and assigned them.
Yes.
Policies and assigned them.
Yes.
When you say you assign them, about how many people are you talking about? How many on your team, not the outside help, on your team do you think was involved in this?
If they could breathe and read and stand up straight, they were involved in the process. I mean, we really did involve pretty much everybody. Certainly, this ragtag band of friends. We were all together. Our nurse manager, Caroline, she helped a lot. Even Holly's mother-in-law had to come and help. So when I say forsake not the fellowship, we didn't forsake anybody who could. Mm-hmm. Anybody who could and was willing, we looped them in to help in. Yeah.
Just my pearls real quick, and can never say this too much, but just pray constantly, pray together, pray individually. What was huge for me, and I shared this last night, was I started going on walks with Jesus like twice a week because I had to, just to unload everything onto him and just so I could breathe. So just pray, and God works through prayer. Like, he comes through again and again for us. So, and I think that pray and wait. There's this like waiting on the Lord, like he's gonna do it. Just trust and have faith. The point about developing the relationships with other FQHCs, I think, is big. We had 2 in Tulsa. One of them was very supportive, very friendly, very collaborative. We have an MOU with them over dental services. The other one was very prickly and cold at first. We're growing that friendship and relationship, but
That's fair.
you just have to show. They ultimately, neither of them supplied a letter of support, but you have to show HRSA that you put forth the effort.
Yeah.
And that there is at least a collaboration on some level. So that, and then, yeah, AI, like Holly said, it's a tool, right? So you have to use it wisely, but I am grateful that I live in the age of AI during this season and tap into it for policy writing and critiquing and narrative writing and all of these things. And then just the resource handout again, a plug for that. And if you're interested, let me know. I can send you that folder. It has some of those PDFs included. So we'll just leave you with this. We'll end with this. We have this saying around crossover, let God do the heavy lifting. And this theme of endurance was huge throughout this journey for us. Hebrews 12 speaks to that and says, therefore, since we are surrounded by so great a cloud of witnesses, let us also lay aside every weight and sin which clings so closely, and let us run with endurance the race that is set before us, looking to Jesus, the founder and perfecter of our faith, who for the joy that was set before him endured the cross, despising the shame, and is seated at the right hand of the throne of God. And that was really key even last night, just stressing, fix your eyes on Jesus, lock eyes with Jesus, and don't look away, because it is a journey and a marathon. So.
Thank you.